Hi, everybody. I'm Chris Flanagan. Welcome to another edition of What's Going Around. Each week, we speak with a doctor around the DMV to see what's going around, what's happening, and I'm really excited. We have such a timely topic today with Dr. Amesh Adalja, an infectious disease specialist and senior scholar at the Johns Hopkins Center for Health Security. We're going to talk about the new COVID variant called Cicada. Dr. Adalja, great to see you, and thank you for joining us.
Thanks for having me.
Yeah, you bet. All right, it's been, the past week or so, we're all hearing now, it seemed like COVID was kind of in the background for a while. Just tell us a little bit about this new variant, what you know about it, and why is it popping right now?
The first thing to know is that even though COVID's not in the headlines, it's continuing to infect people and it's continuing to evolve, just like all respiratory viruses do. Just like we get new strains of flu, we get new strains of COVID. And that's what this new variant, which is being known as Cicada, is. Its technical name is BA.3.2, but they're calling it Cicada. And what it is just another version of Omicron that people are watching because of the cluster of mutations that it has that might mean that it could infect people at a higher degree than prior versions of Omicron. It's not something to panic. It's something that we expect with respiratory viruses. And I think it's just going to be important to see, does it become a dominant variant in the United States? It's not a dominant variant anywhere in the world at this point.
And Dr. Adalja, why is there so much buzz, though, in the last week or 10 days? We're hearing a lot about this cicada.
There's a lot of buzz because the CDC released a report talking about the fact that they're doing wastewater sequencing in many different parts of the country, including in the DC metro area, and they're finding it in about half of the states in the wastewater, but at a very small percentage, like less than 0.5%. And they're just alerting people that this is a variant that the WHO has been monitoring. People like me have been talking about this variant for several months now, and now they're giving us some baseline numbers in the United States. So the CDC releases that report, the press picks it up, and it kind of gets a life of its own, especially some of the websites kind of use sensationalistic headlines, and then that drives more coverage, and it goes on and on and on like that. And that's why this variant is getting a lot more attention than other variants that might not have really garnered that much press attention.
And we know there's been cases in Virginia and in Maryland. Why is it nicknamed Cicada?
So it's nicknamed Cicada because of kind of a callback to the insect cicada, which cicadas, as you might remember, they kind of hibernate for a while and they come out after several years. And this variant is a descendant of one of the original Omicron variants, one called BA.3. And that really didn't do much. And then it kind of was circulating at a very, very low level, but wasn't the main Omicron variant that we were ever dealing with. And now it's evolved, it's gotten more mutations, and now it's come back and it's causing infections. So that's why they're calling it cicada. I don't like those types of names because I think they sometimes give people kind of connotations that aren't really helpful, but it has to do with the fact that it's something that we saw earlier that's now evolved and has come back.
And Dr. Adalja, you touched on a little bit off the top, but how does this compare, this variant compared to other variants and other strains we've seen over the past, 5 years or so?
Well, again, this is part of the Omicron family tree. So it is an Omicron variant. We've been dealing with Omicron since November of 2021. And in terms of comparison, we know that it has more mutations, and those mutations might pose problems for the antibodies that we've generated from infection, the antibodies we've generated from vaccination, and it may pose a problem for the current vaccine strain. But some of those mutations also make it harder for the virus to bind to our cells. So we don't know what it's actually going to do if it's going to become dominant. We know in certain countries like Germany, it represents 30% of the cases. There's no evidence that it's more severe or that it's more contagious, but it is something that might be able to get around some of the immunity that we have. But it doesn't mean that vaccines are going to be useless. It means our current vaccines are going to protect against severe disease, hospitalization, and death. And that's what those vaccines were designed to do. And there may need to be an update in vaccines to cover this variant if it becomes dominant. But that's a huge if. A lot of people are speculating about this becoming the dominant variant, but it's nowhere near the dominant variant at this point.
So, we know we've seen a few cases in both Maryland and Virginia, and I think 25 states in total so far. So is it spreading kind of as you expect, not spreading too terribly rapid? I mean, this is kind of what you're seeing in your expertise?
So we know that there's always going to be one variant rising, one variant falling. That's kind of what always happens with respiratory viruses, whether it's COVID, whether it's flu, whether it's RSV, whatever it might be. Evolution is always continuing. It remains to be seen if this variant, BA.3.2, spreads more widely, becomes the dominant variant. I don't think that we have enough information to be able to predict that, because even in the countries in which it's more widespread, like Germany and Denmark, for example, it's still not the majority of COVID cases. So we don't really know how efficiently it's going to spread. And this isn't something new. This has been tracked since November of 2024. So it's really important to remember that, because if it were going to be some super spreading type of variant, you likely would have seen some more evidence of that. So this may just become part of that swarm of variants that cause COVID that don't really change the risk calculation for anybody. And I think it has to do with the fact that, we're always monitoring respiratory viruses to see how they're evolving, how they're changing, what is their relationship to the strains in the vaccine. That's all normal, and that's always going on behind the scenes, whether or not the media is covering it. It just so happens that Cicada garnered a lot of media attention, so people are asking about it. But this isn't the first time we've been through this with variants.
Right. Yeah, absolutely. You mentioned Denmark and Germany spreading over there a little more rapidly than here. How come over in Europe and that part of the world, do they have fewer? The vaccination rate, is it lower, or what do you attribute to it spreading there a little more quickly than here in the U.S.?
It's likely a multitude of factors, depending upon what other variants are there and where, and sort of a little bit of luck of who's traveling where. So this variant was first described in November of 2024 in South Africa, and it's in multiple different countries, but each country has its own unique characteristics of which variants are there. And remember, these variants are all competing to infect humans. So some might get lucky and infect a super spreader or a person who infects more people, and that variant becomes more dominant. So there's a lot of randomness in which variant ends up on top. Also, it's what they're competing against. Do the other variants have certain mutations that give them an advantage? It's kind of this Darwinian struggle to see which variant comes out on top. And it's going to have different factors and different variables that are playing a role in different countries based on the local epidemiology of infection.
And Dr. Adalja, what are some of the common symptoms? Are they very similar to the other variants we've seen, or does it change a little bit with each variant that we see of COVID?
The symptoms are all the same spectrum that we've been dealing with. COVID-19 is an upper respiratory tract infection. So all those similar symptoms, fevers, chills, coughs, sneezes, sore throats, muscle aches and pains, sometimes diarrhea, all of those are going to be part of the spectrum of COVID-19, irrespective of the variant. And there might be little nuances, but they're nothing that you can really, that's ironclad or specific to a variant. One variant might cause more sore throat than the other, but those aren't really meaningful differences. It's still the same spectrum of COVID symptoms we've been used to for the last 6 years.
And the COVID shot, if you got a COVID shot over the winter or in the fall, this should be okay for this variant?
So it depends on what you're trying to achieve with the vaccine. When it comes to prevention of severe disease, hospitalization, and death, yes, we do anticipate current vaccines will protect against those severe outcomes. However, when it comes to infections, and this has been true not just of this variant, but of many variants, that the vaccines have less durability when it comes to protecting against infection. And they're going to have even less durability against protecting against infection against this variant. However, that doesn't mean that the vaccine has no use, because remember, the vaccine is primarily meant to keep you out of the hospital, to keep people from getting severe disease. And the current vaccine should do that. Whether or not they need to update the vaccine, that remains to be seen. But that would only be triggered if we think that Cicada is going to become a dominant variant. And there's no evidence of that yet at this time. So it would be premature to say we need to change the vaccine at this point for this variant. Even though this variant is getting a lot of press, that doesn't change the actual numbers on the ground.
How often do the vaccines get updated? Is it yearly? Is it every 2 years, 18 months? How often does that happen?
The COVID vaccines get updated approximately once a year. And they had a meeting in December, they being the WHO, had a meeting in December, and they've made a choice. They usually have another meeting around May. This variant will probably be a topic of discussion at that meeting. I don't know if they're going to make any kind of updates to it, but that would be when they would make that decision.
And how recently must a person have gotten a vaccine or a booster to be protected, from any variant for that matter for COVID?
So the vaccines, none of the vaccines are going to protect you or make you impervious to infection. They're not some magic force field. But if you've been vaccinated within the last 6 months or so, you're like, especially if you're even in a high risk group, and that's who we recommend get vaccinated more frequently and stay up to date, the vaccine is likely to be durable for about 6 months at protection against severe disease, hospitalization, and death in the most highest risk persons. When it comes to infection, the vaccine, the ability to ward off an infection is probably on the matter of a couple of months before that wears off and you're susceptible to infection. It will be shorter with this particular variant. But again, this variant isn't something that people are running into in the United States. It's a very small percentage of cases.
You mentioned it's been around since 2024 or so. As an expert in this field, what do you keep an eye on? Is there anything concerning with this variant, as an expert in this field?
Right now, I don't see any evidence that makes it concerning. It does have a cluster of mutations that are likely to be able to get around some of our immunity, but in and of itself, that's not concerning because some of the other mutations make it less likely to bind to our cells. So it's kind of a wash right now. There's no major dangerous characteristics about this that I've noted so far. There's not been any evidence that this causes more severe disease or that it's going to be destined to become a dominant variant. The key issue will be if it does become a dominant variant, does that change the vaccine, the vaccine strain selection?
As an infectious disease expert, somebody who obviously knows this field better than anybody, what really, I guess, fascinates you most about COVID? Over the past 5 years, that obviously, for us lay people, we've never heard of it before 5 years ago. But what fascinates you as an infectious disease expert with COVID?
So nobody had heard of COVID before 2019 because it was first described in humans in December of 2019. So that was a novel coronavirus. But what's really fascinating to me is understanding how certain viruses that are circulating in animal species, and remember coronaviruses and SARS-CoV-2, the cause of COVID, all come from bats, how those first jumps into humans occur. And how do you predict which viruses are going to have that capacity and which ones don't? So we know that coronaviruses like the one that causes COVID, like Middle East respiratory syndrome, like the first SARS in 2003, they all made their way from animals into humans. That interface is very interesting to me and fascinating of how these viruses that have a reservoir in animals find their way into a new host, and how much of that is just happenstance and luck, how much of that can you predict, and can you put in place programs to identify those quickly and prevent consequences like what happened with COVID.
Are you surprised, the consequences of what happened with COVID and, worldwide and millions of people dying? Are you surprised what happened with COVID?
There are aspects of that were very surprising. So once we knew that there was an efficiently spreading respiratory virus in China with no vaccine, no antiviral, that was destined to be a pandemic. And many of us were warning about that back in January and February of 2020 when the first reports from China were coming out. So that wasn't surprising. What surprised me was how bad the policy was, especially in countries like the United States, where the United States was considered to be the most prepared country in the world. We had the best tools, but we had an inability to use our toolbox. And if you can remember back in January, February, half of March of 2020, all it was basically evasion and inaction from the federal government. And that allowed this virus to make its way to the United States, spread undetected, land in nursing homes, for example, and cause massive destruction, which impinged on the ability of hospitals to care for patients. And we had no ability to test. We continue to have no ability to test. We had a lot of people making it harder to get tests in the federal government. And then those mistakes were kind of on a rinse and repeat cycle multiple times. So yes, that part surprised me of how bad the policy was and how bad it got in the United States, not because of the virus, but because of our inaction, because of our inability to actually take the actions that were necessary, the proactive steps that would have been necessary in January and February before you had to do what governors sort of did, which was very blunt tools. So I have lots of surprises about how bad the policy went, but the virus itself didn't surprise me that much.
Doctor, Adalja, when variants and subvariants mutate, do they typically get stronger or weaker?
It depends on how you're defining that.
Okay.
Variants are going to be driven by evolution. In the virus, from an evolutionary standpoint, the virus is attempting, if you kind of anthropomorphize it, the virus is attempting to infect the people. And the people continue to have immunity from vaccines and from prior infections. So evolution is going to drive the virus to develop mutations that allow it to get around some of our immune system. So, in that sense, variants become more contagious. They become more immune evasive. That doesn't necessarily mean they become more severe. That's not what evolution is selecting for. It's selecting for efficiency of transmission. So in one sense, yes, they become stronger in terms of being able to get around the immunity that's in the population from prior vaccination and prior infections, but that doesn't necessarily mean that they're going to cause more severe disease.
Dr. Adalja, will we see more seasonal increases now in cases as the weather gets warmer? We're in spring, heading into summer eventually. Will it dramatically change the landscape at all?
I don't necessarily think that we're going to see a major increase at this time. We usually start to see a wave kind of later in summer with COVID. We have kind of
Hmm.
these, COVID has kind of two spikes. So flu has this one spike that happens in the fall and winter. COVID has a late summer spike and then a winter spike. That's what it's done for the last several seasons. So I expect it will still stick to that pattern. Obviously, things could change if a variant becomes more dominant and there's not much immunity in the population. But I think we're probably still on that pattern unless something changes in terms of the proportion of variants.
We have learned so much in the past, 5, 6, 7 years from COVID, of course. How much have the guidelines changed?
The guidelines have changed a lot in terms of how we advise people when they get COVID, what they should do. Because you have to remember, back in 2020, 2021, COVID was still killing at a very high rate. We didn't have vaccines, we didn't have antivirals, we didn't have home tests for some period of time. And that meant the risk was higher. Now we have a population that is very exposed to COVID. Almost everybody has had COVID multiple times. Many people have been vaccinated. Many people have hybrid immunity from both infection and vaccines. We've got multiple antivirals. We have home tests. We understand a lot about how to treat COVID in the hospital. All of that conditions how we advise people what to do. And we all now recognize COVID is what we would call an endemic respiratory virus, one that is going to be with us year in and year out, just like influenza and RSV and the dozen other respiratory viruses that we always get. So that changes how we make risk calculations and how we give people risk guidance. And I think that reflects how far we've come. Because for COVID now in 2026, we have more tools for it than we do for any other respiratory virus. So that has to be reflected in how people should perceive it, that risk. It's very different in 2026 than it was in 2020.
Yeah, definitely. Let me ask a lot of people are probably wondering they have the at home tests they can pick up at, CVS, Walgreens for COVID-19. Will that detect the Cicada variant right now as well? Will that pick it up?
Yes, all COVID tests will test for every variant. That the variant, the way the test works has nothing to do with the variant.
Okay, good to know. Um, how do you tell the difference, if you don't get tested, between COVID, flu, allergies, especially allergies now, the springtime, there's allergies are everywhere. How do you tell the difference or perhaps a different seasonal illness?
All of the respiratory viruses are going to be clinically indistinguishable. Even I couldn't tell them apart in a patient without a test. They all have overlapping symptoms. With allergies, one of the things that would be different is you don't usually get a fever, muscle aches, and pains with an allergy. So allergies are a different type of phenomenon than a viral infection. So that's one way to distinguish it. Fevers, chills, not going to be common with an allergy.
Dr. Adalja, do you ever think COVID will be eradicated?
No, it can't be eradicated by definition. This is a virus, as we've talked about, that has an animal reservoir. It is in bats. You cannot eradicate a virus or a pathogen that has an animal reservoir. So no, COVID can never be eradicated. It never could be eradicated because it normally resides in bats.
Interesting. Do you ever think we'll see a pandemic quite like the one we saw with COVID?
We may see one even worse than COVID. There are much worse things than COVID. If you think about 1918, influenza, that had a higher case fatality ratio than COVID. There are avian flu viruses that we're tracking now. If one of those were to acquire the ability to spread person to person, we could have something on our hands that is worse than COVID. And COVID, from a pandemic standpoint, Even though it killed millions of people and it was horrible, it wasn't it wasn't near 1918.
Yeah, wow, that's remarkable. As an infectious disease specialist, you mentioned there's other illnesses, diseases out there. Is there one or two in particular that keeps you up at night, and you're just like, wow, this if this ever gets out, forget about it.
It's the avian influenza viruses. We know that avian influenza caused the 1918 pandemic. That is the biggest threat I think that humans face from infectious diseases. And I would have told you that in 2008, 2009. I would tell you that at any time. Avian influenza is always at the top of my list because we know what influenza viruses can do. We know there are multiple avian flu viruses that are circulating now. They are infecting poultry all around the United States. They've gotten into dairy cattle in the United States. And there are human infections that are occurring. So what's really important to make sure is that we have the infrastructure to monitor if any of those human infections go further, meaning they spread from person to person. That's what the danger is. That's what many of us in the pandemic field worry about, especially because we're not doing so much for avian influenza as we could in terms of being proactive, making sure that we're catching all the human cases, making sure we're studying all of the viruses to see are they mutating to become more adapted to mammals.
Yeah, fascinating. All right, Dr. Amesh Adalja, really interesting conversation. I appreciate you taking a few minutes with us here.
Thanks for having me.
You bet.